my role is as the hub of this program. So they need to know that they can reach one gatekeeper, one navigator in the system that will get them through from beginning to their follow-up.
The selection criteria are very pretty strict, that we want to do patients with severe or critical aortic stenosis. And that's usually the velocity of blood flow across the valve has to be greater than 4 meters per second. Or if it's not, they have to have a reason why it's not. If their heart pumping function is reduced, sometimes the velocity is reduced, but they still have a severe narrowing of the valve. So those are the patients we're looking at. And then the second criteria is they have to be high risk for surgery or inoperable.
It's important that these patients are seen and evaluated by 2 surgeons who deem them either high risk or inoperable in order to be considered for this procedure.
So if you're a high-risk patient, you can have this done. If you're not high risk, then you would have surgery, regular surgery.
From there, I bring together all of the various tests that are done on these people to concisely identify what the major issues are as far as their medical history.
Ronnie screens the patients for frailty and disease, and there's a lot of questions that go involved into kind of filling out the, we have a database that we follow through the STS, Surgical Thoracic Society database, and ACC, which is where these patients are tracked. So they're looking at outcomes at a month and a year. So that's the first thing is sizing, what size valve you're going to use. Right now, there are only 2 sizes of valve. There's a 23 millimeter and a 26 millimeter diameter. If the aorta is too small, if it's less than 18 millimeters, we don't have a valve small enough to go in there. Eventually, they're going to have one. And in fact, in Europe, there are valves that are smaller than 23. I think it's a 19 millimeter valve that can be used. If the aortic annulus is too large, the valve won't sit there. It could pop free. And if it's greater than, generally we use about 24, 25 for the maximum size. So that's a 26 valve will go into a 24 aortic annulus. So one, you have to have a sizing study, and that's done with a transesophageal echo. That's a echo probe you put down through the esophagus and look at the annulus. And the other technique is doing it with a CT angiography, where they'll size it and you can get the annulus area, and that's what we use. That's probably the most accurate method we have. Usually it's about 4 to 6 weeks would be the minimum time.
And it's only after we've put all of these puzzle pieces together that we can truly say to someone, we can offer you this procedure. And so we usually have a pretty good sense of how that's going to go fairly early in that process, but there still needs to be a point at which we say, okay, schedule this person and get their pre-admissions work online, and we're going to put them on the schedule. It's usually a sense of relief to them that after all of these tests, that someone is saying, yes, we can offer to help you. I see them during their pre-admission workup. I go to the operating room with them. I see them while they're here post-operatively, and then I follow them up in the office when they come back. They have a 30-day visit and then a 1-year visit, and we'll see them 1 year annually from there on in. It's a lot to go through, but certainly looking at these people who are 1 month to 6 months out and seeing what the improvement is in their physical strength and their outlook on life, it's just amazing.